owners of country across the various lands on which we live and work. I'm joining today's session from the land of the Gurungai people, and I recognise Aboriginal and Torres Strait Islander people's continuing connection to land, water, community, and I'd like to pay my respects to our elders past and present and extend that respect to any Aboriginal and Torres Strait Islander people joining us today. I would also like to thank Dr. Ellie Friedman, who I'll be introducing shortly, who helped to write and review today's course. And ASHM would also like to thank the Australian Centre for Disease Control, who have funded this session today. A little introduction to ASHM. If you're not familiar with ASHM, we are a non-profit member-based peak organisation for health professionals working in HIV, viral hepatitis, and sexual and reproductive health. We partner and collaborate to enhance workforce capacity, advocate, develop resources, and strengthen health systems to address stigma and barriers to care. Our primary work is in workforce development through the delivery of education and training, which includes conferences, courses, online learning, etc. So I encourage you to visit our website, have a look at our upcoming events and online learning, and explore the benefits of becoming an ASHM member. We also have our resource library, which holds a collection of clinical guidelines, handbooks, decision-making tools, and fact sheets designed to support healthcare professionals. I encourage you to explore our resource library, including our Syphilis clinical indicator and decision-making tools, our STI management guidelines. They're all free. You can download them anytime. All right. That's enough for me. I've just introduced Dr. Ellie Friedman, who is our presenter for today. We are very fortunate to have Ellie joining us for this session. Ellie is a sexual health physician, manager, and staff specialist in clinical forensic medicine, sexual assault examiner, as well as a senior clinical advisor to the New South Wales Ministry of Health's Prevention and Response to Violence, Abuse and Neglect program. So I will now pass over to Ellie to start her presentation. And once again, thank you all for joining us today.
Thanks, Chloe, and welcome everybody. Now you should all be able to see my screen, which is a graphic warning. There's some graphic images. There's probably some graphic conversation. So the warning for that is a warning for you, but also I'm just very aware that people are often viewing these presentations in public areas or sharing them. So just be a little bit careful, because some of your colleagues, friends, family, pets might not be as comfortable with some of the images and topics as the rest of us. So, and also just, I always think it's we all work at home a lot now, or we kind of mix up work and home a bit, don't we? And I think it's worth just having that little moment of thinking, actually talking about violence, abuse, neglect, and possibly sexually transmissible infections and pathologies is maybe not something I necessarily want to bring into my home as something normal. So just having that little pause and think. Now let me move on. So these are our learning objectives. We're going to be talking about STIs, but particularly about syphilis, and just thinking about them in the context in which you are all working, and just really acknowledging that everyone here is working in a very different context and space. Probably I had some familiar names and some less familiar names. What we'll do is I'll get you to just type in the chat where you're from, what your role is, what area you're working in, because I think it's really interesting for us to see where everyone else is working. And so thanks for the intro, Chloe. I'm going to tell you a bit about me. So my name is Ellie Friedman. My role is lots of different things. You saw all of that, but essentially I've worked for 20 plus years as a doctor in sexual health and sexual assault services. I'm logged in from Camaragal country. I'm at home in Chatswood at the moment. And I have worked really all of my senior professional life, certainly for the last 20 plus years, as a a doctor in a multidisciplinary team. And I'm really wanted to bed everything we talk about today in that context of working together. Because if we can, the benefits and strengths of us working in multidisciplinary teams is incredible. Like, I think anyone who's managed to work that successfully, where we see each other's areas of strength and areas of knowledge and we work together, you can see how clearly that provides much better outcomes for our clients. And I think it's something we should really work on. So I'm very aware looking, I can see a lot of the chat is about the sound, so that's good, but I can also see a lot of the sound, a lot of the chat is about where you're from, where you're working from, and we've got a really wide variety of geographical locations, of different clinical settings, different roles, responsibilities, and areas of knowledge. So I'm not going to keep all of you happy. I'm sure that for some of you, some of the things I'll talk about are things you already know, and for other people, I might not meet your kind of overriding requirements. But hopefully that we'll use this space as a bit of a start off about what do I need to know in this area? What do I already know? What do I need to know next? But also look at the chat, see who else there you can reach out to, connect with, and use, because none of us are doing this work alone, thank goodness. So another little brainstorm, and this I think is a good one, just to think about. There's two separate questions here and probably very different. What to you, when someone talks about sexual health, and I love the fact that we've got a mixture of people here from a sexual health background and people from a violence, abuse, or women's health background, because I think for those two different groups, when I think about safe sex or sexual health, those are the two things I'm holding in my mind. So just have a think, pop something in the chat if you feel inspired. Two questions. One is, what springs to your mind when you talk about sexual health? And also, why is it difficult to talk about sexual health in your consultations? And if so, why? If you're working in a public sexual health clinic, it's probably very easy to talk about sexual health in your consultations because the patients come in expecting to talk about that. But for many of us, where it's not up and center in our in the title of our work or our job, sometimes it's very hard to bring that up. And I'm really interested for people's views and opinions on that, but also just kind of some of your personal thoughts about those two questions. And we'll kind of answer those, I hope, a bit as we go through. So I'm starting you off with a bit of a case study. And again, just recognizing we're all coming from different clinical spaces. So for some of these, you're going to be seeing this patient in a counselling perspective. Sometimes it's going to be a medical or a nursing perspective. Some of these times they're going to be people who you've heard about in a clinical meeting. But just thinking about these cases and what your thoughts are. They're really just to get us thinking and started. So this is Lily. She's separated from her partner, from an abusive relationship with her partner. It should be an abusive relationship with her partner rather than an abusive partner. Excuse my labeling language. And she's got two young children. She experiences anxiety, depression, and chronic fatigue. Today, she tells you she thinks she needs a medical checkup. She's feeling more run down than usual. Her symptoms have exacerbated and she's worried that there's something else going on. You ask her a bit about that and she tells you that she's experiencing more headaches than usual and she's got some abdominal pain. So, you know, this might be someone who you're seeing in all sorts of contexts and she's flagged that she thinks there might be something medical going on. I'm just thinking, in a case like this, she hasn't mentioned sex. We haven't thought about it. Would any of you suggest STI screening as part of her medical checkup? Would you maybe suggest that she goes into a sexual health clinic or a women's health clinic to see a GP or to see a women's health nurse? Or would that just not be anywhere there on your radar? I'm just interested in whether or not that would come up, or what kind of things Lily might say that would make that come up for you. Any questions you'd want to ask? I'd be interested to know when she last had sex. I mean, I probably wouldn't start that. When someone told me they have headaches and abdominal pain, I don't just jump in with when did you last have sex. When we're thinking about abdominal pain, we might ask some questions about the nature of the pain, whether it was pelvic, what was causing it, whether any other genital symptoms. We might ask if she has a new partner. We might ask if she's had any sexual contact with her ex-partner. I can hear someone in the background. Lovely. Yeah, so I think that someone's put further explore sexual health history rule out. So PID, pelvic inflammatory disease, an obvious cause for abdominal pain. She could have syphilis. She could have something causing herpes, causing some systemic symptoms. She could have all sorts of things. I'm always interested in cases like this where we have people with chronic health issues where we sometimes get very symptoms led and we miss some of the things that we would do when we first meet someone. So she presented to us as someone who was in an abusive relationship, and we probably focused on the abuse and then on some of the medical issues, headache and fatigue. So we may, or the clinicians involved in her care may have never taken a sexual history. We may never have asked about sexual assault within the relationship, and we know that within abusive relationships, sexual assault is very common. We may have never asked her about a new sexual relationship because we may have thought that was inappropriate. We may have a whole area of questions that we've never talked to her about. And so she may never have talked about her sexual health concerns or sexual history because we've never asked her. And we've all been a bit blinkered and thought about the abuse and thought about the medical issues, and we've never taken a proper detailed sexual history. And I would suggest that anyone, I didn't tell you how old she was, but we're assuming she's reproductive age, she's got young children. I would suggest with anyone, but particularly with reproductive age people, that we're always making sure that we have asked some kind of a sexual history. So it's just someone said there beautifully, it's part of our one aspect of holistic health. And absolutely, we wouldn't want to just take a sexual history and nothing else. So why is sexual health important in our work? So, one of the things we know is that irrespective of what area we're all looking for people in different space, in different contexts, but most of the people that we're working with, most of our clients at some point have sex. Some don't, but most do. So it's a really important part of people's lives, and looking after their sexual health is part of people taking autonomy and control and looking after their own health. There's a lot of misinformation and fear about STIs, but we know that STIs can cause chronic health issues and medical issues. So we do need to make sure that we've excluded those for people with chronic health complaints. And also we know that a diagnosis, say, of herpes or syphilis can have impacts on the physical and mental health of our clients. So we need to know about that so that we can support them in that work. Medically, it's really important to know whether or not you've got a sexually transmissible infection, because most people don't want to transmit it to their current or their future partner. And also we think about, for women particularly, or people who have a uterus, the protection of unborn children and prevention of mother-to-child transmission. That's why sexual health is important. But why is it important for us? And I think Lily's case is a good one. If we don't bring it up, who will? And I love Georgina said there, I find a gentle way of introducing this is to ask about hormonal health leading into reproductive health. And yes, often with women particularly, we start thinking about contraception, reproductive health, and then we can move into sexual health. But we do need to address it as an okay thing to talk about. We need to give our clients permission to ask some of those difficult questions. And we need to be very aware that they're getting a lot of information online and from friends, which isn't always necessarily correct. So this is just a bit of a dump here of some of the things that are barriers for us as clinicians talking about sexual health, but barriers for our patients as well. And these are mainly some things we can address more than others. So time constraints is an issue for all of us. So sometimes you might need to make a longer appointment or suggest that the patient comes back for a longer appointment. Sometimes that conversation is going to be held over 5-10 minute consultations. Sometimes we just need to think about what is the most important issue right at the moment. Privacy and confidentiality. It's really important whenever we're seeing any of our clients that straight up we're able to tell them about where this information will or won't go, who will have access to this, who we will not be telling, and what they can do to protect their information. So it's addressing things like whether or not they want information on my health record, whether or not they want their GP to know, and reassuring people about the overarching confidentiality of medical records. I think just by talking about sex and sexual health, we're overcoming a lot of the shame and stigma, but we also need to acknowledge that it is a hard thing to talk about. We can't minimize that feeling of shame and stigma. That just makes our patients feel even more ashamed for being ashamed. Definitely, we need to be aware that for different cultural groups, and if we have a cultural gulf between us and our patient, there might be things that it's hard for us to talk about or understand. And certainly as an old lady, sometimes when I'm talking to my younger patients, they really roll their eyes when I start saying things like, well, us women, because as far as they're concerned, I'm a Martian from the planet whatever. So recognizing those gaps and recognizing they exist. Clearly, we generally don't want a third party present, but sometimes that might be helpful. So just again, gently exploring who the other person in the room is or who the other person in the room should be. For all of us, there's an issue around knowledge gaps, scope of practice, and those are all things that we can hopefully address. I know for nurses particularly, there's some constraints on what you can and can't do, but a lot of that is about understanding those barriers and working out who can fill those gaps. But the knowledge gaps and the clinical relevance are really big ones there, aren't they? We need to find some ways of addressing our own knowledge gaps, of increasing the health literacy of our patients, but also of making sure that if we're asking questions about sex, that our patients understand why we're asking and why they're relevant. So these are just some lovely little kind of, there is going to be a PDF of these slides available so you can take them. And if there's something you want to take away, I think this is a nice one. So these are just some little sentences or phrases you can use to try and introduce the subject. So it's about normalizing. This is something it's an important area of health. I talk with everyone about it. Reassure confidentiality. We're not actually going to talk about minors today. I need to take that out, but we can talk about minors another time, as in young people, not people who work down mines. Minors' health would be another whole thing. For those of you from Western Australia, you're probably very onto that. I'd like to ask you some questions about your sexual activity now. I often say I'd like to ask you some sensitive questions now. I'd like to ask you something that might be hard for you to talk about. So just doing that, but also making sure that we're using the same tone of voice and manner. We're not saying, ooh, we're going to talk about sex now. A long time ago, when I was a little baby doctor and I started working in sexual health, I used to practice taking a sexual history in front of the mirror because I used to blush when I said, I used to stand there in front of the mirror saying, now, was it anal, oral, or vaginal? And I couldn't say that without blushing. And then I realized, apart from, my skin tone issues, that what I actually needed to say is, I'm going to ask you some questions which are slightly embarrassing or that might be a bit challenging. I also find these things hard to talk about. Just acknowledging that these are not things that you talk to all your friends down in the pub about. And that's really helpful. Again, just you all know this. I think probably by virtue of the fact that you've come along here, you know this. But we need to make sure that all of the language we use and the information we give is genuinely patient-centered, authentic, and non-judgmental, and the rest. But a lot of that is by explaining to your patients why you're asking those questions, explaining to your patients why you need to know that, so that they understand you're not just being nosy, but that you're signaling that it's okay to talk about those things. So why are we here? We're here to talk about domestic violence and sexual health. So as I said before, we know that sexual assault is a common element of domestic violence. And even when women disclose that a relationship has been violent, abusive, or controlling, they often won't talk about the sexual assault unless they're directly asked. And again, that might be to do with shame and stigma. It's also because sex is often seen as something that just happens in a relationship. It was just bad sex. I didn't feel like having sex, but he forced me to, or I felt I should. So it's also not even necessarily naming some of those experiences as sexual assault. The thing about sexual assault, it's not just about the sexual, sex against your wishes, but it's also about the fact that women who are in an abusive relationship are much less likely to be able to negotiate safer sex, so condom use, the type of sex they want. If sex is hurting or painful, they probably feel less empowered to stop their partner. So there's a whole host of things that can lead to worse sexual health as an impact of abusive relationships. And we also know that one of the overarching impacts of domestic violence is poor access to health care. So we just need to make sure that if we know about violence, abuse, neglect in a relationship, that we're asking about sexual health. This is just, again, a reminder for all of us that we know that domestic violence, all forms of violence, have direct impacts on health, so through physical injuries and often sexual and reproductive health, but also contribute to worse mental health, worse overall physical health, and often with risk-taking behaviours. So we really need to make sure that women who are experiencing domestic violence have access to good healthcare responses. So this is our next little case study. This is Aisha, who tells you she was sexually assaulted 2 weeks ago by a known male. It was a friend of her friend. They were at a party together. Aisha is 23, and she's coming to the Women's Health Centre for counselling. And she asks you in her counselling session if you think she should have a checkup for sexually transmissible infections. And she'd like some advice on how to organise this. So interested in your setting, and I know for some of you, you're working in a sexual health clinic, you're working in a medical service, might be very easy, but what you would advise someone 2 weeks after a sexual assault, whether there's anything else you would advise her, and how she would organise that. So if people want to pop some answers in the chat or any thoughts that people have about what we would do. So thinking about that. So health care post-sexual assault is kind of is the easy bit. It's very easy. A pregnancy test certainly might be useful. So we know that following a sexual assault, most people who've experienced a sexual assault have concerns about sexually transmissible infections, hepatitis B and HIV. On the whole, your risk of getting an STI through a sexual assault is no higher than your risk of getting an STI through other forms of unprotected sex. But you are less likely to be able to negotiate safe sex in an assault situation. So most people should be offered STI and HIV testing within the prescribed window period. So we say around 10 days for most STIs and around 4 to 6 weeks for HIV. People can have Hep B vaccination if they haven't been vaccinated. And remember, most people have been vaccinated through either the birth program or school catch-up program. So it's only people really under 32, I think it is now, who if they were born in Australia, who are unlikely to be vaccinated. In the case of people men who are assaulted by other men, or people who are assaulted by other people at high risk of HIV, we might consider HIV PEP. Clearly, ASHA's outside the window for emergency contraception, but you have all flagged beautifully that a pregnancy test might be useful. And then some of the other things we worry about are non-fatal strangulation and head injury, which may present a bit down the track. And I can see Jackie and Courtney on the chat nodding there because they are the head injury and non-fatal strangulation gurus for New South Wales. And there's some beautiful guidelines on the Women's Health New South Wales website that I'd advise you look at. In terms of what is available, we also need to think about forensic testing. So ASHA is outside the time frame for biological evidence collection, but she certainly can have an independent recording of her injuries, of the account of the assault, and that can be done through in New South Wales through a New South Wales Sexual Assault Service. So she's asking you, what STIs could I have? I haven't got any symptoms of STIs. So if someone says to you, should I have an STI test? I haven't got any symptoms. I haven't got any pain. I haven't got any discharge. Could I? That means I don't have an STI, doesn't it? What would you all reply? You can tell by the way I'm asking it that the answer is clearly no, because we know the vast majority of STIs are asymptomatic. So STIs can cause discharge, dysuria or pain peeing, pelvic pain, lumps and bumps. So I'm thinking about warts, molluscum, vulval cancers. They can cause ulcers like herpes and systemic symptoms. And Michelle, I'd say depending on the STI, it can be up to 90% of people can be asymptomatic, which is why we like to do a checkup. And our common STIs, chlamydia, gonorrhea, herpes, warts, syphilis, Hep B, and HIV. Now, there's lots of other weird and wonderful STIs out there. The Australasian STI guidelines, which we'll look at later, are a really helpful place to look some of those up. But the vast majority of the time, we're going to be dealing with those common ones. So we talk a lot about priority populations, and those are populations that are defined in terms of epidemiology and to have higher rates of STIs and or are groups of people like pregnant women, pregnant people with whom we may need to do an intervention to prevent onward transmission. So the groups that we particularly are concerned about are men who have sex with other men, Aboriginal or Torres Strait Islander people, young people, we know high rates of STIs, often poor access to healthcare, pregnant people with whom if we manage the pregnancy and manage the infection, we can reduce transmission to an unborn child. Sex workers, again, probably low rates of STIs if they're having regular health checks, but often poor access to healthcare. People from culturally and linguistically diverse backgrounds, often again, that's an access issue. We also know that people are sometimes coming from high prevalence countries, and trans and gender diverse people who often have very poor experiences of healthcare and high rates of abuse. So just think about some of those groups of people we have to hold in mind. Having said that, anyone who says, should I have an STI screen? The answer is almost always yes, because if someone's asking the question, then it means they have concerns about STIs. We need to explore what those concerns are, but there's often no good reason not to do an STI. And yes, older women are often a missed group with STI screening. We assume that women stop having sex around the age of 35. And absolutely, we need to make sure that when we're talking to women, especially, we're often very comfortable talking to older women about their HRT or about their mental health. We need to also make sure that they are having their sexual health needs met as well. So really don't need to think about screening versus testing, but you hear these things, but screening, a true screening test is that we do a kind of population-based thing where we're doing an intervention, we're doing a test on a large number of the population because we want to know what the prevalence of an STI is. Testing is when my patient comes in and says to me, I have got discharge, abdominal pain and ulcers all over my vulva, that would be a test. However, what we're often doing when we think about STI screening is a hybrid between the two, and we often call it opportunistic testing. So I see a young person in clinic who's come in for a repeat prescription of the pill. So we're already having a reproductive health conversation. Actually, let's say we have a young person who comes in for a repeat prescription of her antidepressants. That's probably more likely. So we're not necessarily having a sexual health consultation, but she's age 24, she's sexually active, and I will say, whilst you're here, let's do an STI test, pee in a cup, do a self-collected swab, and we've done that, and we know that because she's in one of those priority populations, she has got a high risk of being positive. We can treat the chlamydia that she's going to have when she comes back, and we have achieved something through some of that opportunistic testing. I don't think it really matters what language we use, but I think sometimes we overuse the term STI screening to kind of think that it's a blanket term, that it always encompasses the same tests and the same, we're always covering the same issues. Whereas opportunistic testing I like a bit better because it's a little bit more flexible, isn't it? We can actually find out what our patient needs and what we offer them, what out of the bank of things that are on offer we can offer them. Okay, little breath. And we'll move on to. I'm under terrible time pressure because I reassured Chloe and Jackie and Courtney that I would be finished on time. They said you've got too many slides. I said no, that's fine. So now I have to talk at 100 miles an hour, and we're going to go over some of these slides very quickly. These ones should have a content warning on for me because I don't mind gross images of genitals, but I do mind stats and numbers. This is much more triggering for me than any of the pathologies I'm going to show you later. So just a really quick one, just really to show you that that STIs are increasing year on year. Now, interestingly, in about 1998, just here where that starts to take off, we started to have better testing. We started to have PCR testing. So I spent about 10 years going, oh, there's no real increase in STIs. It's just that we've got a better test. And then it keeps going up. So I could be wrong. It could not just be that we're having a better test. It could be that we're having some more STIs. This little dip here, of course, is COVID. Probably people carried on having sex, but they might have had fewer tests. And yay! Thank you all for polling. Anyone who wants to add a poll in the chat, we want to know what your top of the 5 STIs up there was in 2004, and yes, it's chlamydia. So we've definitely seen an increase in syphilis and in gonorrhea, but chlamydia remains an extremely common and extremely treatable STI. So chlamydia is very common, and I've really just popped this up here to show you these are converging at 2023. But really, this is the top line is women, the bottom line is male, and the middle line should be in the middle of the two of them because it's the average, it's the total. But generally, we have higher chlamydia rates in women than in men. And if you break it down by age, we see more chlamydia in younger women and in older men. So that probably just reflects sexual partnering, but we need to have a very high rate of suspicion we need to be testing all young people, especially young women, for chlamydia. Now, this slide is a bit dated, I'm afraid. I just noticed that about half an hour ago and went in to try and fix it up and couldn't. But just to let you know that the rates of syphilis, yes, women probably get tested more often, George, and I think that's probably because they're coming in for other reproductive health concerns, whereas men come in with broken ankles and no one bothers. So syphilis is becoming a huge issue, and what's really flagged it for us is that there have been 4 infant deaths, I mean more now I think, and cases of congenital syphilis, and that congenital syphilis should be a completely treatable disease. So again, looking It's still mainly in men, and for a long time we thought that syphilis was really an infection of men who have sex with men, but it's clearly an infection that affects us all. So Australian STI management guideline. You should all have this as a screensaver on your computer at work, I would suggest, because it's got everything you need to know. I use this all the time. I show it, I share it with my patients. It's got guidelines, it's got treatment, it's got really useful stuff. So we don't really need the rest of the talk. You can just go and look at that. I am not going to talk in any great detail about chlamydia and gonorrhea. You will get a PDF of these slides, and this is really useful. But you can see that there's huge numbers of women, especially with chlamydia, who are asymptomatic. But women who have symptoms get a vast range, or people who are symptomatic get a vast range of complications and presentations of chlamydia. And these are the yucky pictures you've been waiting out for, a cervix and a urethral meatus, and it tends to be a clear, snotty discharge if we see anything at all. Gonorrhea, less common, but still not uncommon. And again, something that was very much an infection of men who have sex with men, but is really generalized into the population now. And what we see there, there aren't many graphic pictures in this, I promise. The discharge tends to be more milky, greeny, yellowy. And as well as having the genital symptoms, people can get disseminated gonococcal infection. They can get quite ill with that. Neisseria gonorrhea is related to Neisseria meningitidis, so people can get quite unwell with that. And newborns can get eye infection. So it is an infection that can present anywhere. Case study 3. Kaylee is planning her first pregnancy and she wants you some health advice. And she says she's worried about STIs because her partner, Daryl, has genital herpes. He's always had genital herpes, and she's concerned that the baby might have genital herpes. She looked it up on Google, which is always a good thing to do. There were terrible pictures of neonatal herpes. And she's also asked if there are other STIs that can be passed on from a mother to a child. Any thoughts about what you might tell her? Or who you'd refer her to? Your always answer to this is, if I can't tell her, how would I find out? So, yeah, most STIs can be passed on from mother to child. We really worry about syphilis for many reasons. We should be testing every single pregnant woman for syphilis. And so any baby born with congenital syphilis, you'll hear me saying this 17 times in the next 7 minutes, is a failure of the public health system. But syphilis is passed on throughout pregnancy. It's passed on through the placenta. So it's a real problem. Whereas if you look at most of these infections, they're passed on. HIV is largely passed on during birth and breastfeeding, even though it can be passed on cross placenta. It's really if we have bleeding or an abnormal pregnancy. So if you have a well-managed pregnancy, then we can really minimize the risk of HIV. Same with Hep B. But syphilis is passed on through the pregnancy, through the placenta, and that's what makes it particularly dangerous. So our answer to Kaylee, going back to Daryl, is that actually genital herpes can be a reason for delivery by C-section if the mum gets herpes for the first time in the 3rd trimester of pregnancy. So if Daryl's had pregnancy, if Daryl's had pregnancy for 20 years, that's great. If Daryl's had herpes for 20 years and Kaylee and Daryl have been in a relationship, then the chances are that Kaylee already has antibodies to herpes and she's probably at low risk of passing it on to the baby. But I would suggest that that's one of the few times that we do a herpes blood test for antibodies, because we can reassure Kaylee that if she's got antibodies to herpes, that there's no risk to the baby. Some women who have recurrent herpes do elect to have a cesarean section, and that's fine, but the epidemiological data is quite clear that the risk is a new acquisition of herpes during pregnancy, and that can be hard to manage. Happy to talk about that another time. And down here is just a link from within the STI guidelines. Because it's a brilliant guideline, there's a whole section on pregnant people that you can access. So let's talk about syphilis. We've got like about 3 minutes left, and this is what you all came for. So syphilis is caused by Treponema pallidum. It's a kind of wiggly worm, little spirochete bacteria. So there's an infectious diseases person on the list I saw there. So I'm making this up as I go along. So syphilis is one of those really weird infections. It's asymptomatic in most people, like most STIs. But it lasts for a long time, and we know from some very unethical old studies in the US, particularly where people were left untreated with syphilis, that some people just grow old with syphilis and die with syphilis, but not from syphilis. Some people will probably get better and clear the syphilis, but for most people it becomes a chronic infection if it's untreated. So you start off with a primary chancre or ulcer. So chancre is just a really old English word for an ulcer at the site of primary inoculation. So the site where you got the infection, you get an ulcer that lasts that appears around 9 to 90 days after you've been exposed. So often that's on the genitals because it is a sexually transmissible infection. It may be in the mouth, it may be in the anus. I worked with a guy years and years ago who was a dentist, he wasn't a dentist, he was an oral medicine specialist. And this was in the 1990s, in the kind of peak of early HIV. And he diagnosed a huge number of people with oral primary chancres, but you wouldn't normally see them because they're often at the back of the mouth. Primary chancres we always talk about them as being a painless ulcer. They're not entirely painless, but they're big, rubbery, nasty looking ulcers. And they look like they should be painful, but they're much less painful than they are. And they're often singular. Herpes ulcers are small, shallow, little blistery ulcers that don't look that painful, but when you touch them, the patient jumps off the bed. So relatively painless, big single ulcers, I'm always thinking syphilis. Remember, they could be inside the vaginal canal, inside the anal canal, or inside the mouth, and we might not see them. If we don't pick up a primary chancre, then they'll go on in about probably 6 weeks to 3 months later, 6 months later, 6 weeks to 6 months later to get secondary syphilis. So secondary syphilis is where the treponemes have been released from the immune system into the blood, and we've got a systemic illness. So people feel unwell, they get a flu-like illness, like many other viral infections. They often get a rash, and it's a rash that can affect the palms of the hands and the soles of the feet. It's one of the things you have to learn at medical school, which rashes affect the palms of your hands and the soles of your feet, and syphilis is one of them. They can cause hair loss. They cause these funny flat warts called condylomata lata, which look like flat warts, and they're often in moist areas, so around the anus, around the vulva, sometimes in the armpits. And often people are diagnosed with secondary syphilis, they're feeling unwell, and they get neurological signs because syphilis is an infection that likes the nerves. So they may get a single palsy, they may get some eye signs or blindness, they can get stroke-like symptoms. So weird neurological symptoms is sometimes the first time we pick up syphilis. That resolves. So sometimes people are just going, oh, you had a flu-like illness, you had some funny neurological things, your eyes would, you had some retinal issues, eyes were funny, you're all better now. We don't need to worry about it if we haven't picked up the syphilis. And then they have something called latent, or they have something called latent syphilis. So they can just be asymptomatic for a very, very long time. But eventually, most people will develop in kind of years from the primary infection these lesions called gummas, which are basically a bit like the primary chancres. They're these kind of thick lesions, and they can be in the skin, but they can also be in the heart and the neurological system. So people can present with things like aortic aneurysms or heart dissections of the heart arteries because they've got a gumma, they've got a lesion growing in the heart. But it's unusual for people to present with tertiary syphilis. We normally pick them up before that, but that could be years after the primary infection. Okay, we have a poll. my poll master. How can syphilis be transmitted? Yay. Vote now. Got no responses. Yay. We've got yes. So kind of an easy question, isn't it? We know that all of those are ways of transmitting syphilis. So the chancres are full of treponemes, and they're very infectious. So we should be adding in syphilis testing to our STI checkups. And I think that's a really big point for those of us who aren't necessarily working with priority populations. I work a lot in my clinical work with reproductive age women, and I'd say just do a chlamydia and a gonorrhea. That's all we need to do. We need to be adding in a syphilis blood test. We really need to make sure that pregnant women or women who are planning pregnancy have regular STI testing. Men who have sex with men. Generally, we're good at testing men who have sex with men. Sadly, that the cases of congenital syphilis, many of them have been amongst Aboriginal people. So we need to make sure we're adding those tests in and making access to those tests available. But we also need to, for the clinicians, think syphilis. You know, we spend a lot of time telling the neurologists and the ophthalmologists and the general medical people, think syphilis. Don't, you know, people who are doctors who are my age were taught, as I was at medical school, you'll never see a case of syphilis. We've got rid of it. So it's people often don't think about it. This is another really useful resource for you, but also for you to shove under the nose of your friendly GP who isn't actually says, oh no, don't be silly, it couldn't be syphilis. So again, I think these are really useful things to have out and around in a clinic space. So as I said before, we really worry about syphilis in pregnancy because syphilis readily crosses the placenta. So it's not enough for us to just worry about syphilis at delivery. We have to worry about it from the moment of early pregnancy and all the way through. And we know that it can cause miscarriage, early infancy death, but it can also, if the baby, for a live birth, it can cause congenital disability and illness. It is a preventable disease, and we need to make sure that we're all thinking about syphilis in pregnancy. So this is Lila. Lila is 30 weeks in her second pregnancy. First pregnancy, no problems at all. She's got a 3-year-old son. She's just been told that her blood test for syphilis is positive. She doesn't know if she's ever been tested before, and she says, is this likely to be a new infection? She lives in Western New South Wales, and she had regular antenatal care for both her pregnancies. What do you think about Lila and her syphilis test? Is it likely to be a new infection? Kyla, I cannot answer your question. The longer the exposure to syphilis and uro linked to increased detrimental harms to the baby. I don't think so, but I would need someone who is more expert than me to answer that. So my understanding is that it's often to do with when in pregnancy the exposure across the placenta to syphilis happens. So I think essentially, yes, you know, if you remember, you're not sharing the maternal blood supply and placenta for the first few weeks. So, but if you had syphilis in utero in early pregnancy, you're more likely to have a whole system issue. So it's partly to do with when in pregnancy. It's also partly to do with the syphilis stage. So a mum with secondary syphilis is actually very likely to have a pregnancy loss or a miscarriage, whereas a mum with latent syphilis has a lower treponeme or load and is less likely to. So there's more factors than the length, but you'd need someone more brilliant than me if that were possible to answer that. Anyway, what do we think about Lila? What are we going to tell her? We can look it up. So we think it's probably going to be a new infection. We're hoping that if she's followed the protocols, that she had at least one syphilis test in her last pregnancy and that she had and this is her second blood test in this pregnancy, so it is likely to be a new infection. So we can treat her. Oh, we've got another poll, which we've answered, but we can still put it up. So we can treat Lila, and if we treat Lila now, we're going to reduce the risk of any harms to the baby. And the treatment is penicillin, which is safe in pregnancy and safe for mums. So it's really, really straightforward and easy. So the difficult bit is diagnosing it, not treating it. Yeah, so we now have new guidelines which are, so we've got 12 congenital syphilis cases in New South Wales alone. So we're now recommending 3 syphilis tests in pregnancy. One at the first antenatal visit, so 12-week visit, one at 26 to 28 weeks, and one at, just before birth. Now, we know that probably most people won't have all 3 of those tests, but it means that as long as they get 2 out of 3, we'd like everyone to get 3, but it means that even if people don't attend for all of their antenatal care, we're getting some good opportunities to test. So why don't people have tests? Like, why aren't people rocking up for their tests? We know the big issues are often around accessibility, cultural factors, so especially for people who've had poor experience of health services, and poor health education. And again, all of the groups that we've talked about, we've got often complex social situations, and healthcare during pregnancy isn't the big issue. So we all need to think about in our systems, in our services, how can we make a difference to that? Okay, so what I want all of you to do for homework is think about who you refer to, who you personally in your service you refer to for diagnosis, treatment, who's your expert, who when you want to, who am I going to go and find out the answer to the question about when in pregnancy, what the determinants of damage in of high risks in pregnancy are. So go and identify some referral pathways for your patient. What we like to think about when we think about referrals is making sure we're making a warm referral. We're not just sending our patients off with a piece of paper in their hand, but that we're making contact for them with the service we're sending them into, and that we know that the person we're sending them to is nice, patient-centered, and appropriate, as well as being good at their job. I shouldn't have to say that in 2026, but these things are important. I am going to whiz over contact tracing because you're quite right, we ran out of time, but I am going to stop here for a second. So again, you're going to get all of these slides, but just making sure that you have got some of these resources through ASHM and through the Sexual Health Info link. These are all really useful services, and none of us should be managing things that are outside of our day-to-day knowledge alone. It's not fair on our patients if we pretend to be experts in things we're not. And as I said at the beginning, I did speak very quickly, but really most of it is really just thinking about where do you go from here? What do you need to know more about? And I really would look, I was saying to Chloe earlier, I am sending a lot of people these days onto the ASHM website because they have good talks, but they also have lots of self-paced modules. So you can just work through a self-paced module on sexual health, STIs, HIV, and I think that that's something that we're all time poor, and just fitting in some of those things can be really, really helpful. So I would recommend that. And also, as I said before, Jackie and Courtney have built up an amazing set of resources on the Women's Health New South Wales website, particularly around non-fatal strangulation in domestic violence and in general. So I think all of those are really useful resources. And I am happy to answer questions. Obviously none live here, but happy to be contacted via ASHM, or probably half of you can contact me directly.
Thank you so much, Ellie. You made it perfectly to time. We knew it. You could do it.
We did rush through contact tracing. You will have to go
That's
home and read
okay.
about contact tracing now.
There's the contact tracing guidelines if you really want to read up on
Yes.
it in detail. Yes, huge thank you to Ellie. Wonderful presentation, very, very insightful and valuable. I just want to say a huge thank you as well to Courtney and Jackie from Women's Health New South Wales for all their support on this session.